Dear colleagues, welcome to a further edition of our Pain Solution Congress. Today we are talking a little bit about the headache of our patients, especially we talk about the cervicogen headache caused by some dysfunction in the upper cervical spine and some dysfunction between C2, C3. Most of our patients with cervicogen headache have a problem in the segment C2, C3. In 70% of cervicogen headache, this is the reason in this area. The patients describe us very often similar symptoms. They describe the pain beginning in the suboccipital area. They show the area between C0, C1, or more often between C2, C3. C2, C3 is in 70% of the headache patients caused by the cervical spine the problem. And it's not a problem of hypermobility, it's mostly a problem of some restriction. It can happen that they have got a blocked situation because of any trivial movement. So it's impossible to treat the patients to avoid such a locking situation between C2, C3. And if they get headache because of some restrictions, C2, C3, they describe it very often similar. They describe it that it starts in this place, unilateral or bilateral, and it goes up in cranial direction above the ear. And behind the ear, the pain starts to move in ventral direction like this, and they describe very often a pressure pain behind the eyes. If they describe such a kind of pain, it's in 95% of the patients a locked or restricted mobility in the segment C2, C3. So, as a qualified doctor or therapist, it's necessary to be able to assess it first, this segment, and in a second step, to mobilize the restriction. The mobilization of this area or manipulation of this area needs a really good, not only a good knowledge, but more really good hands and a good coordination of the doctor or therapist who tries to mobilize this. So now let's go at first how to assess this segment C2, C3, and to find out if there is a restriction or not. Now we start to assess this segment C2, C3. We can palpate on the facet joints with our thumb and index finger, and it's very nice in this area because you are really able to feel the mobility of each facet joint. I palpate with thumb and index finger. I grip occiput of the patient and I can move occiput inclusive C2 into flexion, and I will feel the flexion gliding in the facet joint. I can test the extension. I will feel the extension gliding in the facet joints, and I can check the side bending, and I feel on one side the flexion gliding, and on the other side the extension gliding of the facet joints. On this way, we get information about the mobility in this segment. The next step, I show it to you on a patient. On a patient, it's exactly the same. I try to feel at first processospinosus of C2. I go on both sides with thumb and index finger, and I test the monosegmental flexion between C2, C3. I test the monosegmental extension between C2, C3, and I don't know. And I test the monosegmental side bending. Now I get extension gliding on the right facet joint, and at the same time a flexion gliding on the left facet joint. Let's look. On this way, I get the information about restricted mobility in both facet joints between C2, C3. As a first step of treatment, we continue with, or we start with some soft tissue techniques in this area. We can start with functional massage to relax the muscles and to feel if the patient is able to relax or not. That's very comfortable for the patient. In most cases, they relax very effective. And if they are relaxed, it's much easier to mobilize this segment. After treating with a soft tissue technique, we can start with mobilization into sitting position. For this, I stabilize C2, C3 from dorsal cranial to ventral caudal. I pre-position the upper cervical spine, inclusive C2, into flexion, side bending to the right, rotation to the right. I grip around C2 on the left side, and now I mobilize C2 on the left side in ventral cranial direction. And on the right side, with my shoulder against his forehead, I mobilize C2, C3 into extension. So I get a flexion gliding on the left facet joint between C2, C3, and an extension gliding on the right facet joint also between C2, C3 to mobilize for restricted right rotation. Another possibility is to continue in supine position. In supine position, I can also test the mobility with my index fingers on C2, C3. Very easy is to test the poor side bending. Side bending to the right, side bending to the left. We found again some restriction. We want to mobilize. So one mobilization technique is to block the lower cervical spine, the whole lower cervical spine, to get a maximal effect on the restricted segment of C2, C3. So for this, we block the whole cervical spine into side bending to the left. If we pre-position the lower cervical spine into side bending to the left, we get always immediately a left rotation of all vertebrae. So now we have got a blocked situation in the lower cervical spine in side bending to the left and left rotation. We grip around C2, C3 with both fingers or both hands and change the side bending of C2, C3. Now we have got, as in the lower cervical spine, a side bending to the left with the left rotation, but we change the side bending of C2 to the right side, and we push at the same time with this part of my index finger into left direction. On this way, I keep the side bending to the left in the lower cervical spine, and I get the side bending to the right between C2, C3. And now I am doing a three-dimensional movement. I am doing a flexion gliding on the left facet joint, and I move the right facet joint in dorsal, caudal, medial direction. So it's a three-dimensional movement. And on this way, I get a specific mobilization of C2 and C3 for restricted right rotation. That means we improve the extension gliding on the right facet joint and a flexion gliding on the left facet joint. How it looks like on a real patient, I show you in the next step. Okay, now let's work on a real patient. I palpate C2, C3. I make a side bending to the left in the whole cervical spine. Now I get a left side bending and a left rotation in the whole lower cervical spine. I change the side bending between C2, C3 and push with the basis of my index finger from the right facet joint in left direction. Now I get a right side bending between C2, C3 and keep the side bending to the left below. And now I make a three-dimensional movement with flexion gliding on the left facet joint and extension gliding on the right facet joint. And I use gliding mobilization grade 3 to have a really stretching effect on the capsular structures of the facet joints, which are responsible for the restriction. A very nice and very effective technique. A further possibility of mobilization is a gapping mobilization, also for today in the segment C2, C3. For the gapping mobilization, I go with the basis of my index finger on the segment between C2, C3 on the right side. I lift up the head and the head of the patient is on my forearm. And I grip with my fingers around the patient's chin. And now I can make a poor gapping in the segment I want to mobilize. The patient, we can use this technique as a mobilization technique or also as a manipulation technique. I push with the basis of my index finger from the right side parallel to the vertebrae to the left direction. On this way, I get a gapping on the left facet joint. If I use it as a stretching technique, the patient should describe me very precise a stretching effect on the left facet joint. We hold it for at least 8 to 10 seconds if the patient has a really restricted mobility in this segment. If the patient has got only some locking situation, we can also manipulate with this grip if we did all the security tests before. Tests for ligamentum alare, ligamentum transversum, and arteria vertebralis. We can take up the slack, go back, and then we are doing the manipulation exactly in lateral direction. Another possibility of mobilization is with gliding mobilization or manipulation with locking below. Now we want to mobilize C2, C3 for restricted left rotation. We can block the whole cervical spine with side bending to the right. We grip around C2, C3 with the ulnar side of the left hand. Which position do we have now? We have got a flexion, side bending to the right, and left rotation in the lower cervical spine. We have got a blocked situation in the lower cervical spine. In this situation, we don't mobilize because if we want to mobilize, we need a coupled movement. So with flexion, side bending to the right, rotation to the left, we block the whole cervical spine. Now we want to unblock C2, C3. I go with the basis of my index finger on the right side of C2, here. I go with the ulnar side of with my left hand between the segment C2, C3. And I change the side bending only in the segment C2, C3. And keep the side bending to the right below. That's a little bit difficult. You need a really good coordination. I make with my forearm a gentle supination movement. And you can see now I change the side bending only in the segment C2, C3. I keep the side bending C2, C3. So I've got in this segment flexion, side bending to the left, and left rotation. That means a coupled movement. And in the segment below, we have got flexion, side bending to the right, and left rotation, which means a non-coupled or blocked situation. If we have got this position, we have got a maximal effect of our mobilization or manipulation in the segment C2, C3 for restricted left rotation. I go here, lift up, everything is blocked. I unblock C2, blocked, unblock, blocked, unblock. This looks very easy, but it's really very difficult because of the coordination of the therapist. And now I mobilize with the basis of my index finger C2, C3 on the right side in ventral cranial direction, in the gliding direction of C2, C3 on the right side. And I can do it as a mobilization technique. At the same time, keep the side bending to the left. Or I can do it as a manipulation technique. Both is effective. I manipulate if the patient has got a blocked facet joint, and I mobilize if the patient has got a restricted mobility because of a shortened capsular structure. I can show it once again on the skeleton. I take contact between C2, on the right side of C2 with the basis of my index finger. I take also contact between C2, C3 on the left side. I preposition flexion, side bending to the right and left rotation. I change the side bending between C2, C3 like this. And now I give an impulse on the right side of C2 in ventral cranial direction. You see here very nice the position of the facet joint. So I have got to mobilize or manipulate in this direction to get the maximal effect for the restricted flexion on the right facet joint, or for the whole segment for the restricted left rotation. Of course, we are doing the mobilization or manipulation only if the patient has got a negative security test. So you should be able to test at first the stability of upper cervical spine, especially ligamentum alare, ligamentum transversum, and arteria vertebralis. And if these security tests are negative, then you are able to mobilize or manipulate on this way. In most cases, after such a maneuver, the patient describes immediately they feel like a more blood flow in this area of the head, in the area of the headache, and they should get better. If the headache is connected with the cervical spine, they should feel better immediately after the treatment. They should have immediately much bigger range of motion. very nice to test is the rotation, and they should describe you immediately less pain. Of course, I expect some tension of the muscles around this area for longer time, so I advise the patient to put some heat in this area or take a shower or a bath to relax the muscles, because if the locking situation is for a longer time, for some days or weeks, all the muscles around this joint are very tightened, and it's necessary to relax the muscles, and this needs some days. I hope you got some information about mobilization of the segment C2, which is very often responsible for the headache of the patient. Try it. If you have got questions, please contact me or Maxim. I wish you all the best. I wish you a nice congress, and thank you very much for your attention.